everyone, Professor Davis here. In our last chapter we're going to look at in medical terminology is going to revolve around oncology. Now, oncology is going to focus in on the study of cancer, and cancer can occur in any of the body systems. And so because of this, it's at the end because we're going to see that every body system is going to potentially be involved. No tissue, no cell is immune to this. And so let's look at our definition here. So cancer is defined in two main ways. We do see a neoplasm or tumor is characterized by the uncontrolled growth of cells that tend to invade surrounding tissues and metastasize to distant body sites. And so neoplasm is translated literally as new growth. And so this is why it is like a synonym. It means the kind of same thing as tumor. Now, not all neoplasms are actually cancerous, all right? And so you can end up having a tumor or a growth, and it's not going to necessarily be cancer. Cancer arises when the defects in the genes, specifically the DNA sequence on our chromosomes, that regulate cellular reproduction or production and repair are not corrected. And so because of that, it's just continuous growth and more mutations occur, and it causes this cancer to develop. So cancer can be any of the large group of malignant neoplasmic diseases characterized by presence of malignant cells. Okay, and so we're going to come back to some of these terms as we go through this. So let's talk about a primary tumor versus a metastatic cancer. Metastatic means that it's spread. So a primary tumor is going to be example like a lung cancer that originated in the lungs. The neoplasm is at the site of origin. It's in the location that it originated from. Now, metastatic cancer or metastasis is going to be where the cells from the original tumor spread to other parts of the body. So taking our example of the lung cancer, if it's advanced lung cancer and it has spread, it has metastasized, you could see that there are going to be a growth or tumor in the liver, but the cells originated from the lungs. They broke off and they spread to another area. Now, there are lots of different causes of cancer, but most are not necessarily known specifically. In reality, it is a combination of two things. Heredity is one. For example, certain inherited types of cancer like colon, breast, and kidney cancer, those are going to have a lot of times a family history. This is why when you go to the doctor, they have you fill out a form and have you fill out the family history of cancers. Now with this, it does not mean you will definitely get it. It just means that you are more prone due to the fact of having a family history. Now, in reality, it's a combination of your genes and environmental factors. Environmental factors are substances that increase your chance, and these are going to be known as carcinogens. Carcinogens increase your chances for cancer. So one of the best examples of a carcinogen for lung cancer is smoking. Okay, and so if you smoke cigarettes, if you smoke and you use vapes, any of that kind of stuff increases your risk because those potentially are going to mutate the cells in your lungs. All right, and so there are a lot of different carcinogens that have actually been identified. And this includes like excessive alcohol consumption, asbestos, arsenic. We do see formaldehyde, soot, vinyl chloride, solar radiation like sunlight, UV rays, tobacco use. All of that stuff could be increasing your risks. All right, so this is just some examples. So what happens when the cells start to get mutated? What happens is they start to transform. This transformation is known as carcinogenesis. Carcinogenesis is the process of malignant transformation of normal cells into cancer cells. Now, this process can take many years to complete. All right, and this is why we actually see, unless it's a genetic mutation that the individual is born with and we start to see development of cancer right away, you don't normally see cancer until later in life because you've had a buildup of these carcinogens, this buildup and transformation that has been occurring over many years. Now, differentiation is the process of cells becoming specific cell types to perform different functions. This is normal. Cells should be doing this. So once they become a liver cell, they do the job of a liver. Once they become a heart cell, they do the job of the heart. They don't get to decide otherwise. The problem is in cancer cells, they don't get the differentiation. There is a mutation that changes, and they no longer are the cells that they used to be. They don't perform the liver job. They don't perform the heart job. They go rogue, and all they do is just divide and make more and more of these immature, undifferentiated cells, and that's what creates a tumor and causes us problems. All right, so in this picture, you'll see that we have two kind of types of tumors. The first one over here is encapsulated. You can see that it's encapsulated, it's intact underneath the skin, and in this case, we would consider this benign. And we're going to talk about some more characteristics of a benign tumor in a minute. On the other hand, over here, we see that this tumor is more chaotic. It's not encapsulated, it's invading tissues, so it has these like crab-like extensions going out and invading the tissues. We see that it's also coming in contact with blood vessels as well as the lymphatic system so that it can spread. It can move to other areas. These are going to be what we consider malignant tumors. So looking at this, we do have a comparison. Benign tumors, if you're going to have a tumor, you want a benign one. And this is because it's slow growing, it's encapsulated, it's non-invasive, meaning it's not invading into the other tissues, and it normally has what we call small cell nuclei. These guys are the ones that are the more mild form. Okay, now depending on where this is, it can cause major issues, even though it's putting just pressure on related tissues or nearby tissues. But for the most part, this is going to be the more simple form. The malignant tumors, however, are more of a problem. They rapidly grow. They are very invasive, meaning they spread out into surrounding tissues. They metastasize to distant sites. So it started in the lungs, but now it's in the liver and the kidneys as well. We see anaplasia as part of this, which means the cells lack differentiation. They do not look like their original cell anymore. And they have enlarged cell nuclei. And so this is more of a problem, okay? And so these are going to be a comparison between the two types of tumors. Now, what kind of route do these guys take if they do spread to other areas? Okay, if they do metastasis, they move to these other areas. How do they do this? Well, they can have a direct extension into neighboring tissues. Those are those kind of finger-like, crab-like extensions into the tissues nearby. We also see that they can also start to break off and travel through the lymphatic system and the lymph nodes. So the lymphatic system can act as a highway for them to move through. Now, not only can they travel through the lymphatic system, they could also travel through the blood vessels. Okay, so if cells break off and they move through the blood vessels, they could be deposited at a distant site. We also see invasion of body cavities straight through diffusion, moving from the high concentration of the tumor to a lower concentration in a other area. Now, what are some common sites of metastasis where it breaks off and it goes somewhere else? Well, the lymph nodes are a common site, bone, lungs, brain, and the liver. Those tend to be areas. So if it starts out as breast cancer and it breaks off and uses the lymphatic system or the blood vessels to travel, a lot of times you see lymph node involvement in bone and liver issues. All right, when we talk about breast cancer. But these are just some of the more common sites. All right, so again, some naming of tumors. We can call it benign. We talked about that a little bit ago. We could also use the suffix "oma" added to the end. And so this would be things when we're talking about for benign, we could say a fibroma, an adenoma, a lipoma, chondroma. Those are all going to be benign types of tumors. Okay, so this is an example here for benign. On the malignant side, though, we do see that oma can be used as well, but this would be things like sarcoma, carcinoma, adenocarcinoma. So that gave even more information. So some exceptions, though, are going to be lymphomas and gliomas. Malignancy also can be graded. Tumor grading is performed by anatomical pathologists to review the tissue and surgical specimens in order to know what we are dealing with. Malignancy grading is going to look at the cell maturity. So they take a sample of the cells through a biopsy and they look at how mature the cells are. If they resemble what they originally were, we have a lower grade. If they are undifferentiated and they are very immature cells, we have a higher grade. So cell differentiation is another thing they look at. The difference in appearance from the original form. These are all going to be cytopathology studies, looking at the cells, staining them, looking at how mature they are, all of those things in order to give a grade. So let's talk a little bit about grades. So if it is going to be a grade 1, so these refer to the amount of cell differentiation in a malignant tumor. In grade 1, the cells still closely resemble the normal parent cells. So if this started in the lungs, they look like lung cells still. At the other end of the spectrum though, grade 4, they're undifferentiated high-grade tumors. These look nothing like the original cells. And then you have grade 2 and 3 in between. All right, and so this is where a lot of times we would see grading. Now, grading is a little different than staging. When you hear people say that they have stage 4 cancer, that's different than grade 4 sometimes. Okay, and so it's really important to know that grading and staging are kind of separate. You would get both if you get a cancer diagnosis. Okay, but the grading is looking more at the cells specifically. Okay. Stages, however, are going to be talking more about the tumors. So the exact location of the tumor, the size of the tumor, and has it spread, and if it has, where, how far. Okay, so this is looking more at the characteristics of the tumor itself. So one of the staging types of criteria that's used a lot of times is known as TNM staging. So this was developed by the American Joint Committee for Cancer Staging and End Results. And they look at 3 things. So the T stands for tumor size. So we're going to look at the tumor. N stands for the regional lymph node involvement. So the node involvement. So are the lymph nodes in the surrounding area by the tumor, are they involved? Do they have cancer cells in them? And M stands for the distant metastasis. Did it spread somewhere else? Okay, so this is what we're looking at for TNM. Now, numeric subscript indicates the degree of each category. So they may do T1, N0, M0. This is a small localized tumor, for example. It has no lymph node involvement. It has not metastasized. Okay, and so they'll use this kind of framework, the TNM, with little subscript numbers in order to help with the diagnosis of this. All right, so let's talk a little bit about tumor terminology. We talked about OMA being part of that. And so we see adenoma, chondroma, fibroma, lipoma. These are all benign. It's an OMA follows the name of a cell type. Okay, so adenomas are going to be the cells that are found in glands. Chondroma are cartilage cells. Fibroma are fibroblasts. Okay, so the name follows a cell type. Whereas when you have sarcoma, carcinoma, and lymphoma, those are considered malignant. Okay, so when we see here, this is what we would see with it being more of a tissue type versus a cell. Now, this is where a glioma doesn't follow the rule. Okay, the glioma is telling you the cell. It's the glial cells. But because it is a very spreadable cancer in the brain, we have an issue there with it being a glioma. Same thing with lymphoma. Those are going to be lymphocytes, but they're spreading throughout the body, so it's a malignant type of cancer. All right, and so this is where we're looking at the tumor terminology. Some of them don't follow the rule. All right, so this brings us to some diagnostic tests. We do see that there is going to be bone marrow biopsies that could be done. These consist of aspiration and microscopic examination of the bone marrow. Okay, so that's what we look at for a bone marrow biopsy. We also have a sentinel lymph node biopsy. This is performed to determine if cancer has spread to nearby lymph nodes, especially when we talk about breast cancer. We see a dye or a radio isotope is injected to identify the sentinel node, which is then removed and biopsied to see if cancer is present. The Papanicolao smear, this detects cancer in the uterine cervix or vagina. We call this a pap smear. And so they take some of the cells and they're scraped off of the cervix and the utera and in the vagina, and they then look at them microscopically for transformations or differentiation issues. We also have tumor marker tests. These are going to measure the levels of biochemical substances associated with the presence of certain cancers. And some of these can be found in blood. Okay, so they can do a blood test. Some can be found in urine. And then we do see things like prostate specific antigen, or PSA, can be found in their urine and blood. We then have the SPECT test, SPECT. This is a variant of a CT that uses a rotating camera and radioactive substances. This is going to stand for single photon emission computed tomography. And so it's just a very specific type of CT scan. So let's talk a little bit about some cancer warning signs. We do see that cancer encompasses a group of hundreds of diseases. I mean, there are so many different types of cancer. And so we can't necessarily give a set of symptoms that's going to be true for everybody, every person, every type of cancer. But we do see that cancers can vary greatly based on the gender, the age, the geographical location, the ethnic group. We do see some of that, but some of the cancer warning signs are the same across the board. And so these are things that if you're noticing several of these things take place, we should get it checked out and looked at. So first one is anorexia. Anorexia is going to be where you don't want to eat. Now, this is not anorexia nervosa. That's going to be a psychological disorder. This is going to be where you just don't feel good, you don't want to eat. There's a little typo here. The next one is fatigue. Now, this is not just being tired. This is overly tired. It's going to be a type of fatigue where the person can't seem to get out of it. Bruising. If you have excessive bruising that continues to happen, it could be a sign. A sore that does not heal. It does not heal, needs to be checked out. If you have major changes in your bowel or bladder functions, you need to get that checked out. If there's a lump present, this is one of the main things that we need to do to check for breast cancer, is looking for lumps. Chronic indigestion. Indigestion that happens continuously. It's always an issue. Hoarseness. We start to see a hoarseness that takes place and it will not go away. And then changes in a wart or mole. Those need to be looked at more closely because it could be a good indication of skin cancer. So let's talk about some of those types of skin cancer. We have basal cell and squamous cell carcinoma. These two rarely spread, and they get their name based on the location within the layer of the epidermis. However, they can do local invasion and they can destroy underlying adjacent tissues. And so we do need to get them looked at and treated, but they are not going to be malignant type of cancers. All right. And these are going to be found in areas where a lot of times sun exposure is common. Now, malignant melanomas, they arise from melanocytes, and they're the most malignant type of skin cancer, and they will metastasize, okay, if given a chance. And so these guys can spread to far off places. About a third to a half of lesions originate in pre-existing moles and freckles, and so this is why they need to be looked at. Kaposi sarcoma is often seen in patients who have AIDS, and these are those lesions we talked about in the integumentary system that are found along the skin. So here are some rules for skin cancer self-detection. They use the ABCDE method for this. And so A looks at asymmetry. Does it have a lopsided growth? Are the edges asymmetrical now? We also see B, border. Is it irregular? Did it have a normal shape and now it doesn't? C, has the color changed? D, diameter. Is it larger than a pencil eraser? If it is, you need to get it checked out. Okay, and then E, elevation. Is it raised above the skin surface? Or evolution, has it been changing over time? So these are some things that you need to look at when you have moles or freckles, and you can help detect these and then go see the doctor, the dermatologist. We also have cancer in the body system terminology. These can be found in other areas. So you have glioblastoma multiforme. This is going to be in the nervous system where the glial cells are going to be the problem. We then have a nephroma. Nephroma are going to be the nephron cells in the kidneys. So this is going to be part of the urinary system. Osteosarcoma is going to deal with the osteoblast. It's going to deal with bone tissue. Endometrial carcinoma is going to be that inside endometrial layer of the uterus. So it's going to be like a uterine cancer. Leukemia is going to deal with the blood. Mesothelioma is going to be found in the lungs. Seminoma is going to deal with the male reproductive system. And so make sure that you review where these are kind of located. There's going to be some questions I know that come up with what system do these come from? And again, a lot of these terms, that these root words, these terms come from previous chapters that we have already covered. So guys, there's three major cancer treatments that we need to look at. And the first one is surgical excision. So removing the problem, okay? And so we then have radiation therapy, and then systemic or biologic therapy like chemotherapy, bone marrow transplant, or immunotherapy. So let's take a little closer look at each of these. So we do see here with the surgical interventions, you can do a surgical excision. So we're going to be the primary treatment. It's the best for small tumors that are present in only one organ. And we're just going to cut the whole thing out. Okay, if it's a small one, we're going to take it out. We also can do a surgical biopsy. This may stop cancer if it has not spread. So we can able to take part of that out. This is definitely applicable in skin, stomach, colon, breast, and uterine cancers. We also have a resection. This is an excision of significant parts of surrounding tissue and lymph nodes. It's a larger area, so we have to resect and take more parts out. Exenteration is an extensive surgical removal of a tumor, its origin, and all the surrounding tissue. So this is even taking it a step further. And then we have debulking, which is removal as much tissue mass as possible, followed by radiation and or chemotherapy. So debulking is going to be, not only are we going to take it out, we're going to hit it with radiation and chemotherapy on top of that. So the next thing is the radiotherapy. The goal of radiotherapy is to deliver a maximum dose of radiation to the tumor tissue and a minimum amount to the healthy surrounding tissue. So we want to pinpoint where we're sending this radiation. This may be done alone or in conjunction with surgery like we talked about earlier. This uses X-rays or gamma rays to destroy the malignant cells, okay? So we have fractionation, and this is the use of small units administered over time to minimize the tissue damage. Brachytherapy consists of implantation of radioactive material directly into the tumor. This could be a temporary or permanently placed type of radioactive material. Then we have stereotactic radiosurgery. This is where they use a gamma knife surgery, which delivers a large dose of radiation from several different angles to intracranial tumors. So these are going to be those that are found in the skull. Then this brings us to chemotherapy. So chemotherapy is the use of chemicals to treat cancer. Ideally, the cytotoxic drugs are going to be used to selectively kill large numbers of tumor cells without harming healthy cells. However, we do know that chemotherapy drugs are so toxic it does potentially cause issues for the individual, but we try to find medications that can damage those cancer cells but hopefully keep our cells okay. We also see immunosuppressants can be used, and this is to kind of slow down or inhibit your immune system, especially if they're the culprit. We also have radiopharmaceuticals. So radiopharmaceuticals are medications that can be used for diagnostic purposes when we talk about the radiological side, but they also could be used for treatment with certain types of cancers. Can be used in conjunction with surgery and radiation treatments as well. All right, so another thing we want to talk about here is apheresis. This is used in treating various diseases such as leukemia. So there's a blood withdrawal, components are selectively removed, and then the remainder is reinfused into the patient. The removal of specific blood components could be what we would consider the platelopheresis, where removal of platelets, leukapheresis, which is removal of leukocytes, or plasmapheresis, which is removal of the plasma from the donor. All right, and so these are just some examples, and this is going to be where it's dealing more with the blood. Some other biological therapies that could be done are bone marrow transplants. Bone marrow transplants may be used for matching a donor to stimulate normal blood cell growth. Okay, so we would want to take out theirs, because remember, the bone marrow is where the stem cells are located. Stem cells can be can become red blood cells, white blood cells, or platelets. So we may need to go to the source if the bone marrow is the problem. Another is we could use immunotherapy. This is the use of immunostimulants and immunosuppressants to prevent and treat diseases. One example when we talk about here is stem cell transplants, and this can be coming from a donor from a patient before chemotherapy was undertaken, and then we give it back to them. So this is their own. Stem cells are located within the bone marrow, and so it's important that we could draw those out before treatments began for some individuals. During the chemotherapy treatments, it could cause destruction of this, and then we could replace them with the stem cell transplants. All right, and so we've already talked a lot about the different pharmaceutics that are present here. You have the anti-neoplastic, cytotoxic, chemotherapeutic agents. These all destroy or inhibit the growth of cancerous cells. Immunosuppressants are going to inhibit the immune system because they suppress it. And then radiopharmaceuticals are going to assess various internal functions. That's the diagnostic tool part. But they also could be used to treat certain cancers and tissue hyperfunctions. And that's where it becomes more therapeutic medication-wise. All right, last but not least, let's go over a few of our abbreviations located in here. You saw the ABCDE. That's the self-cancer, self-detection rule that we talked about. BPH is going to be benign prostatic hypertrophy, which we've already talked about as well back in the reproductive chapter. HPV is human papilloma virus. PSA is prostatic specific antigen test. RIA is the radioimmunoassay test. SNB is the sentinel node biopsy. So remember, injecting in the radioactive material so it identifies the node, and then taking the biopsy from there. Again, this is not all of them, but it's a lot of the abbreviations. If you have any questions as you're going through the chapter, please let me know.